Hello. So we're going to get started. I would like to introduce Dr. Blevins first. He is, as you know, endocrinologist and clinical professor in UCSF, and he is the medical director of California Center for Pituitary Disorder at UCSF, one of the largest pituitary centers across the country. He earned a medical degree at Quinlan College of Medicine at East Tennessee State University and completed residency in internal medicine at University of Alabama Hospital. After completing a fellowship in endocrinology at Johns Hopkins Hospital, he served on the faculty at Emory University for 4 years and then at Vanderbilt University for 9 years. He has been in UCSF for about nearly 10 years. It is a pleasure to have him today, and please welcome Dr. Blevins.
Thank you, Dr. Nang. It's always a pleasure to come to Fresno to see old friends and make new friends. I have to say, though, this is probably the first trip I've made where it's actually colder here than in San Francisco. I usually come in the summertime when it's rather warm here in the valley. So I didn't come prepared with clothing attire to deal with the chilly weather, but I've survived. So Fresno winter. What I'd like to do today is talk to you about hyponatremia and some of the advances in therapy that really, it's hard to call them advances because the drugs we'll talk about have been out for about 7 to 10 years now. Probably the only advances are my way of thinking about hyponatremia over the time frame that I've practiced medicine, and I'll review some of those things as well, some of my approaches given my experience. I work in the Department of Neurological Surgery at UCSF, so I have the opportunity to see a lot of patients with hyponatremia, and that's really my focus or my bias, I would say, is hyponatremia in neurosurgical patients. So a lot of my strongly and maybe less strongly held beliefs about the disorder come from that practice arena. So just a little bit of epidemiology, and I'm sure that you all probably have a patient in the hospital today with some degree of hyponatremia. It's said to occur in 15% of hospitalized patients. However, if you look at serum sodium that's more severe, more restrictive as defining hyponatremia, sodium of less than 130, the incidence is 1% and prevalence of 2.5%. Interestingly, and we all see this, about 2/3 of cases are hospital-acquired hyponatremia. In our practice, as a patient comes into normal sodium, their sodium drops at some point during the hospitalization, either as a consequence of something we've done with fluids or a new development in regards to their disease process. If you look at different settings in the ICU, 30% of patients with hyponatremia, subarachnoid hemorrhage patients on a neurosurgical service, 30%, traumatic brain injury, 12% in most series, heart failure, 28%, HIV, 30%, and the list goes on depending on the arena that you're looking at in the hospital. What we do know is that the risk of hyponatremia is greater in the elderly patient and also in those with more severe illnesses, and that's basically what this slide is trying to demonstrate. Hyponatremia also has been associated with an increased mortality, and in these studies it's salted out as an independent predictor of mortality. I often think of hyponatremia as an epiphenomenon of severe illness, so that the more severe your heart failure, for example, the more likely you are to have hyponatremia. Same thing is true of cirrhosis of the liver and other disease states as well, meningitis, brain tumor, for example. So we know that if it's an epiphenomenon, the more sick the patient, the more likely you are to be hyponatremic, and you would think that it's really not then a good predictor of mostly of illness and therefore of mortality. But it turns out it's an independent predictor across different disease states, and when you take out disease severity, the likelihood of hyponatremia increases your likelihood of the presence of hyponatremia increases your likelihood of mortality. And these are 3 studies looking at hospitalizations, and you can see here the mortality in patients with hyponatremia in blue, and in green those patients who were normonatremic across 3 separate studies. Definitely increased mortality in each of those centers. This is a slide that shows you the survival in heart failure if you have a normal serum sodium versus having a higher serum sodium. And you can see with a low serum sodium in heart failure, there's about a 25% mortality after 400 days in that setting. And again, this maybe reflects it's an epiphenomenon. People aren't necessarily dying of the hyponatremia, but it sort of reflects the severity of the pump failure, for example. And these slides are regarding cirrhosis of the liver, and you can see here the MELD score. Mortality is, or survival is higher the lower your MELD score, and it falls the higher your MELD score. And also the survival probability falls with serum sodium. And these slides are the Kaplan-Meier curves for cirrhosis of the liver. And you can see here the survival for normonatremia and cirrhosis. Sodium's 130 to 135 and less than 130, with 50% of people being deceased in about 4 months if their sodium's less than 130, having cirrhosis of the liver. And as I understand, the latest MELD score revisions actually include hyponatremia now to sort of as a predictor because of this type of survival information. Let's review some physiology, and this is sort of a cartoon of the hypothalamic pituitary unit. And just to remind you, arginine vasopressin secreting neurons are in the supraoptic and paraventricular nuclei of the hypothalamus, and they have axons that traverse the hypothalamus and the pituitary stalk and then terminate abutting capillaries in the posterior pituitary. And those terminal boutons of those axons actually store the vasopressin that's synthesized in those neurons. There's an osmoreceptor in the anterior hypothalamus that senses changes in plasma osmolality, and those either fire or become quiescent depending on what the osmolality is doing, and then sort of direct the paraventricular and supraoptic nuclei to either fire and release vasopressin and its neurophysin or to be quiescent. There's also a thirst receptor, a thirst center in the anterior hypothalamus near the lamina terminalis that's separate unit from all of this that senses changes in osmolality and drives us to become thirsty if our osmolality rises. Now you can see here that there are actually some descending and ascending autonomic pathways that are involved in this process as well that regulate vasopressin release. So there's information come from the carotid sinus and probably aortic arch and other vascular structures that feed into this area to give the hypothalamus an idea of what blood pressure and blood volume are doing. And those things can regulate, as I'll show you later, when I have a graph to show you, can regulate vasopressin release as well. So it's a pretty complex system in this very small area of the brain. This slide shows you what happens to vasopressin levels with increases in plasma osmolality. So as osmolality rises, the osmoreceptors fire, vasopressin is released into the circulation. One thing I'll show you here, and this illustrates thirst coming on in osmolality about 290. And this thirst is logarithmic, so you get a little bit thirsty and you get a lot thirsty the more your osmolality comes up. This is important, as we'll see on a later slide. But you see this slope of the line here. These are individual data points, and you can see the slope of the line. Everybody has a set point where they'll start releasing vasopressin in response to a rise in osmolality, and that's different for all human beings. And it probably has a lot to do with what your serum sodium level is going to be, or what your little mean and standard deviation is if you repeated your serum sodium level. And everyone has a different slope of the line here for that relationship between vasopressin and osmolality. Now, if you have a low blood pressure or low blood volume, you're going to release vasopressin at a lower set point, and you're going to have a steeper line to get more vasopressin to hold more water at the kidney to try to increase your vascular volume. If you have a high blood pressure or high blood volume, the slope of the line is going to change and become smaller, where you're going to release less vasopressin per unit change in osmolality. Once vasopressin is released into the circulation, it finds its vasopressin receptors, and there are three types. There's V1A, V1B, and V2 receptors. The V2 receptors are the ones in the renal collecting duct that are important in free water absorption with regards to the talk on hyponatremia. But just to remind you, the V1A receptors are in vascular smooth muscle and platelets, and these are the ones that lead to vasoconstriction. So that's why we might use arginine vasopressin for a GI bleeding patient. or DDAVP for a patient with von Willebrand syndrome, for example. There are V1b receptors in the anterior pituitary that lead to ACTH release, and thus vasopressin is a stress hormone as well. And that makes teleologic sense for something that's going to allow you to hold free water to be also something that's going to stimulate ACTH release and cortisol production by the adrenal glands. There are proteins called aquaporins that are present throughout the nephron, and they're in different places. The ones that I like to focus on are the ones in the collecting duct epithelium. And what happens is vasopressin binds to its receptor, the V2 receptor, and it leads to signal transduction, second messenger production, and this leads to not only the increased production of these aquaporins, but also increased shuttling of these aquaporins or water channels to the apical membrane of the collecting cell. What happens then is this cell is now permeable to water. This is the urinary space, which has a lot of water in it. And then water can move across the cell membrane because the cell is more hyperosmolar than urine. And then water moves from the cell across the basolateral membrane into the medulla of the kidney, where the vasorectin and the countercurrent multiplier system and all that create that hyperosmolar system. And it's through vasopressin then binding to its receptor, creating these water channels that allows water to come from the urinary space to the vascular space to get reabsorbed, to then lower the plasma osmolarity that was increased and therefore led to vasopressin secretion in the first place. This shows you the relationship between plasma vasopressin and urine osmolality. And remember that a urine that's maximally dilute is probably 100 to 200 milliosmoles, depending on the age of the patient or the normal subject. And the maximum concentrating kidney ability of the kidney in a young, healthy person is probably 1,200 milliosmoles per kilogram of water. And you can see here that as vasopressin levels rise, vasopressin does its thing in the kidney. You resorb water from the urine, and therefore the urine concentration goes up. And that's what you're seeing here. Now, I think it's rather interesting. When you get to vasopressin levels of 5 to 10, most of us have maximally concentrated our urine. And if I went back and showed you the other slide, you would see that at vasopressin levels of 5 to 10 is where, for most people, the thirst mechanism kicks in. So it's a really nice system that's working while you're on rounds or in clinic seeing patients or whatever, so that you make vasopressin in response to changes in osmolarity, and this conserves water at the level of the kidney. And then when you really have the sense that you're thirsty, you really should go get a drink because you've maximally used your vasopressin, and the system is working to enable you to be able to do your job without being thirsty all the time. So if you're thirsty, it really means you're behind on your water. So this is a nice sort of dynamic slide that puts it all together and gets us to hyponatremia. I've sort of talked so far about this system working in the setting of a water deficit, where plasma osmolality increases, vasopressin levels rise, you decrease your renal free water excretion, your plasma osmolality normalizes. But the reverse is true. This is a sort of a dynamic system that's a negative feedback system. If you have a state of water excess, let's say that there's people that drink a lot of water for radio shows, or you drink a lot of beer at a party or whatever, your plasma osmolality decreases and you shut off vasopressin. That will cause you to have increased renal water excretion. You'll notice it by urinating more regularly, and that allows your plasma osmolality to normalize. So it's sort of a sliding scale here between vasopressin and plasma osmolality. Osmolality falls, vasopressin will shut off. Osmolality increases, it will increase as well. This algorithm for hyponatremia is something that I've seen in textbooks since probably the 1980s when I started medical school. And it hasn't changed. It's the same algorithm. So a lot has changed in medicine over the number of years or so that I've been involved. This is one thing that hasn't. We still look at hyponatremia and address patients according to the volume status of the patient. Now, while that may be difficult, you can still get a pretty good idea of the volume status of most patients at the bedside. And if you use your history and your physical, you can figure out most of the cases of hyponatremia. So you start with assessment of volume status, and let's first talk about the hypovolemic patients. Those are the patients who have hyponatremia, because they have lost more body salt than the water they've lost, but they've lost both, so they're hypovolemic, they're tachycardic, they have a high BUN to creatinine ratio, for example. Maybe their creatinine's even a little bit elevated in this setting. They're orthostatic and orthostatically tachycardic. And these are patients where usually it's fairly straightforward by history and physical. If they're a burn patient, vomiting, diarrhea, third facing pancreatitis, etc. If they're on a thiazide diuretic, the mineralocorticoid deficiency can be a hard one to pick up. You have to think about adrenal insufficiency, mineralocorticoid deficiency in the patient who might not otherwise have it clear. Some people have salt-losing nephritis due to sulfa drugs, for example. So most of the time you can figure this out. Adrenal insufficiency is the big one that you can't miss in that setting, or even simple isolated hyporeninemic hypoaldosteronism can cause hyponatremia in these patients. The other one that is an easy group are the hypervolemic patients. These are the patients that have an increase in total body sodium and a further increase in total body water. The total body sodium is increased usually because the renin-angiotensin-aldosterone system is activated. These are the patients with cirrhosis and heart failure. They all have activation of the RAS system because they're having less blood flow and blood pressure to the kidneys, so they retain salt, make aldosterone, retain salt to try to increase blood volume because the baroreceptors and the sympathetic nervous system is sensing that the patients vascularly deplete. So that's why they have the increased sodium. That's why spironolactone is used in cirrhosis patients, for example. But they also have an increased body water because of further teleologic mechanism of vasopressin release. Remember I told you the autonomic ascending pathways will change the set point and the slope of the line for vasopressin secretion. So these patients have activation of vasopressin secretion because of that autonomic activity. So they have an increased total body water because of vasopressin secretion, increased total body sodium because of activation of the renin-angiotensin-aldosterone system, and therefore are edematous. So that's clearly they have volume excess. You see that. They have pitting edema. And the history is pretty easy. You know they have nephrosis or protein-losing enteropathy or cirrhosis or cardiac failure. And then the middle one are the euvolemic patients. These are the patients that are simply waterlogged. Their total body sodium is normal, so they're not edematous. They're not orthostatic. They have no pulmonary edema. They simply have an increase in total body water. And these are the ones where it's usually a pure physiology of vasopressin hypersecretion. And there are a number of different causes. The ones to keep in mind before you can diagnose SIDH are glucocorticoid deficiency, and this is usually isolated cortisol deficiency, but some people also have mineralocorticoid deficiency if they have Addison's. And then hypothyroidism can affect free water clearance and can lead to hypernatremia. And then, of course, those patients with SIADH, drug-induced, whole host of drugs. The common ones that I see are the analeptic medications and some of the antipsychotic medications and antidepressants. But then SIDH is due to lots of different tumors, lung carcinoma, anything going on in the head, brain tumor, meningitis, neurological surgery, for example, and then almost anything going on in the lung, even mechanical ventilation can cause pneumonia, tuberculosis, for example, can cause hypernatremia. I had a note from our ENT physicians the other day where they saw a patient with fungal sinusitis, and they think that was the cause of the hypernatremia because there's no other cause, and it resolved with debridement surgically of the fungal infection. So almost any disease process can cause hypernatremia and SIDH. But if you think about it from sort of a standpoint of what's the volume status of the patient, urine output, BUN, creatinine, uric acid, etc., you can figure that out. Just as proof of concept, people have measured vasopressin levels in patients with SIDH, and you can see here that a majority of patients, not all, have vasopressin levels that are inappropriately normal or elevated in a setting of hypoosmolarity, where this would be the normal range. Interestingly, a number of people have vasopressin levels that are apparently normal or less than 1 in a setting of hyperosmolarity. The thing I would say about this is that we don't really understand whether there are other vasopressin compounds at play here, but the assay is not a highly sensitive assay. It's not like your TSH where you can get down to 0.001 on the measurement, and we know a TSH of 0.1 is different than a TSH of 0.005, for example. So it's conceivable that these people at 1 probably are making too much vasopressin. Also, keep in mind that anytime you do a blood sample, you're getting a single biopsy of 5 seconds. It takes the time for that tube to fill up. So a vasopressin level of 1 doesn't mean that it's not, at 10, 5 minutes later. So some tumors make vasopressin erratically, and it may be that we're simply sort of missing it based on the timing of the blood draw in some of those patients. So the symptoms and signs of hyponatremia are pretty nonspecific. And I would say that if you go to clinic today, you'll have patients who have at least one of these symptoms or signs on your docket today or on your list of patients to see. And as a result, the best way to diagnose hyponatremia in your practice is suspect it. And especially if you have a patient who has a clinical setting. Mine's easy. A patient had brain surgery. They come with nausea and vomiting. Well, our residents now know to check the serum sodium or send a patient to a local hospital to get a sodium checked because that patient might have hyponatremia. But, nausea and vomiting, delirium, confusion, weakness, lethargy, myalgias, cramps, dizziness, hiccups, dysarthria. This is all from an article published in 1993 in the Journal of Medicine, which always was one of my favorite journals, some of the best state-of-the-art reviews. The thing they left out was headache. Patients with acute hyponatremia, headache, flu-like symptoms are the most common symptoms and signs they have. So when we have a patient who has pituitary surgery, if they get a headache and flu-like symptoms within a week, we know to send them to the hospital because they're probably hyponatremic. So it's suspecting that it might be the underlying problem, given the overall health of the patient, that really will help you diagnose hyponatremia, given these symptoms and signs. Obviously, the more acute the hyponatremia, the more symptoms you're going to have. The more severe the hyponatremia, the more symptoms you're going to have. And these are a list of the symptoms in patients with sodium levels less than 115. And you can see that the encephalopathy that you get with that, altered sensorium in about 50% of patients, seizures, nausea, vomiting, gait disturbances, dysarthria, coma, etc. This symptom and sign complex is modulated by the underlying disease state. So if I have an 80-year-old woman with SIADH from the nursing home who comes in with a UTI, she may not have any symptoms at all at a sodium of 128. But if I have a patient who has a history of a glioblastoma who had surgery, may have a seizure at a sodium of 128. So the underlying history of what's going on with the patient will modulate the symptoms and signs, whether it's acute or chronic hyponatremia. So the other thing I want to sort of remind you, and I think that, and I put this slide in here because I think people forget this. They see a hyponatremic patient and think, well, the patient's hyponatremic, and they don't realize that it's like any other disease process. It's like a pneumonia where you get infected and then it ramps up and then you're infected and then you get treated and it's slowly going to resolve. Or it's like a myocardial infarction that happens and then evolves with things that can happen over time. But hyponatremia, just like any other disease state, has an initiation phase. Then you're going to have, if you have SIADH, for example, a maintenance phase where it's going to be raging. It's going to be at a certain level. And then it's going to resolve and be resolved. And you may, when you see that patient come in when they are just ramping up their SIADH, or they've had it for a week, or it may be over, and all you have to do is figure out how to get rid of the excess water they've already held on to. And I think it's important to think about hyponatremia in that way when you're starting therapy and then evaluating your response to therapy. Because a lot of times we'll start treatment and say, gee, this isn't working. Is my diagnosis correct? It may be correct. It may be you just need to be more aggressive because their disease is ramping up. Or they may have a very robust response to your treatment, and that may be because the SIADH is gone and you're just seeing them at the end of it when they have retained the extra water, and you just have to get rid of that extra water. So you have to keep that in mind as you're evaluating and managing your patients. This is a paper from an endocrinologist who basically took a look in their hospital, 104 patients, sodium levels less than 125, and he applied standard textbook criteria. And I don't think this person managed all of these patients, but it was at the hospital this individual trained at. And he basically looked at the textbook criteria and reviewed the charts. And based on textbook criteria and applying that to a review of the medical records, deemed that 42% of diagnoses were incorrect. At least the diagnoses that people had written in the chart as the potential cause of the hyponatremia. And 33% of the patients in their facility had what he referred to were significant management errors where the wrong thing was done in that particular setting. The overall mortality of hyponatremia at this degree in his hospital is 27%, and it was essentially double in those where he found errors in management versus those where patients were managed accordingly. And the conclusion of this study was hyponatremia is difficult. We all see it, but it's difficult to get a grasp on. And there's a lot of error that can be made if you sort of misjudge what's going on with the patient. I think the other take-home message is if you have a local expert, rely on that person, work together. We're here to work as a team, and we should put our collective wisdom together and try to learn more about this. I'll speak for myself that when I was an internal medicine resident, I had a lot of people with hyponatremia on my service. By the time I finished my 3 years of residency, I didn't really know what I was doing with hyponatremic patients, and we sort of fluid restricted them all, and some got better and some didn't. And then when I became an endocrine fellow at Hopkins, I was getting these consults, and the buck was stopping here, so to speak. And then when faculty, even more so, it sort of behooved me to understand this particular disorder. And since I do pituitary disease and work with neurological surgeons, it came clear to me that I needed to learn everything I could about this particular disorder. And as time has gone on, it's another one of those things where the more you learn, the more you realize you don't know. But you do get, I think what you do find is that you can get a handle on most of the cases as time goes on just by delving in and learning more. And you do realize that it is sort of a trial and error, and that's partly because some patients have a mixed picture. Some of the neurosurgical patients that I see, for example, have cerebral salt wasting and SIDH together. So they might look like they have a little bit of a volume depletion, and they may look like they have a little bit of SIDH. And you try one therapy. If that doesn't work, you try another. And sometimes you have to use 2 therapies. When it comes to treatment, the biggest thing that people are concerned about is central demyelination. And we'll talk more about about that in a minute. But the most important thing to do to prevent demyelination in the patient is to treat the patient. The second most important thing is to prevent demyelination. And what we have learned about central demyelination and brain volume adaptation is that if you have acute hyponatremia, the brain edema is marked and there's minimal brain volume regulation. And the risks of hyponatremia outweigh the risks of correction. So if you know the patient's sodium was 137 yesterday and today it's 125, hyponatremia is a threat to that patient's life. They're going to get brain edema and maybe herniate, and they need to be treated. If you have a patient who comes in from the nursing home and is asymptomatic and has a very low serum sodium, you don't know how long that patient's had the disease. Their brain probably has volume regulated to the hyponatremia, and they're chronic asymptomatic hyponatremic, and the risks of correction are greater than the risks of hyponatremia in most of those patients. Not all, but most of them. And then if you have a patient that has chronic symptomatic hyponatremia, maybe the sodium is 122, you don't know how long it's been there, but they seem to be a little bit goofy or confused or whatever, they may have some brain edema, partial brain volume regulation, and the risks are pretty balanced. So that's one way to sort of look at it. Interestingly, this has been studied. So if you sort of look at patients and equate them to be acute hyponatremia where you know it's real, you know it's recent, and those patients who have chronic hyponatremia where you don't know the duration or their sodium is low and they have no symptoms, and then they look at correction for chronic cases or acute cases, chronic hyponatremia acute. And if you look at those patients with acute hyponatremia, whether they had a slow rate of correction of sodium or a rapid rate of correction of sodium, they had uncomplicated disorders. And that's the general thing. If you have acute hyponatremia, who cares how fast the sodium comes up? You can get it up quickly. The brain hasn't volume regulated. You're not really putting that patient at risk for demyelination. If they have chronic hyponatremia or unknown duration and you do a slow rate of rise that's generally uncomplicated, if you have a rapid rate of rise in sodium, most people still have an uncomplicated case, so we get away with it probably most of the time. And then a few patients have transient sequelae, and some have permanent sequelae of a rapid rise in sodium. And these are the ones that we worry about. These are the ones that sort of enter the mind of most physicians who have a patient with hyponatremia. I don't know if any of you have ever seen central demyelination. I've seen it about 7 times in my life, and it's not a pretty sight at all. And I'll talk a little bit more about the patients that I see it in a moment. This is an MRI of the brain showing pontine myelinolysis or central demyelination. Here it is in other areas of the white matter. The key thing to remember is that this myelin injury occurs anywhere there's myelin in the central nervous system. So I've seen patients with spinal cord lesions, for example. It's not just in the pons, like we used to think it was called central pontine myelinosis or CPM. So you get the demyelination anywhere. And these are the symptoms and signs of that. And generally speaking, the time course of this, let me just see if this slide is on it. No. Okay, so let me tell you a little bit about central demyelination. It's a fascinating process. When I was in medical school, we were taught that there's this intimate association between myelin and the neurons, and that intimate association was necessary for myelin to work. And that if you had a brain that became edematous, then volume regulated and lost its edema to adapt to the hypernatremia, with chronic hypernatremia, and then raised the serum sodium concentration, you would have a neuron that then shrank because it would give up water, and then that would cause a separation of the neuron from the myelin, and then the myelin died. That's what we were taught when I was in medical school. What actually happens, though, is that the neurons seem to do pretty well with these changes in rapid changes in sodium, but the myelin does not, and you end up getting myelin fracture. And myelin can repair itself. There are all sorts of microglial cells and stem cells in the brain, and that's the real problem. And if the myelin fractures, it becomes damaged, and then it incites the development of stem cells to become microglial cells, which come in to try to repair the damage that took place. But they release cytokines, inflammatory cytokines, and all sorts of different things that attract the immune system, which then starts damaging myelin and killing neurons. And that's what central demyelination is all about. That process takes a week to 10 days to start. So a patient who has a rapid rise in sodium, you might say, gee, we got away with that. They don't have any symptoms a day later. But really, that process takes 7 to 10 days. So if you have a rapid rise in sodium, you need to see that patient a week later in clinic just to evaluate them. And that's where you'll start to see these symptoms and signs, usually about a week after the rapid rise in serum sodium, when that microglia has a chance to proliferate, the immune system revs up, and you start losing neurons and losing myelin as a result of what is thought to be a reparative process. Interestingly, in rat studies, lovastatin and tetracycline prevent the recruitment of microglia. So you can take rats and make them hypernatremic, keep it there for a while, correct their serum sodium, cause demyelination, and they get all sorts of neurologic problems. But if you give them tetracycline or lovastatin, they don't get the demyelination at all. And that's because those drugs are known to inhibit microglial proliferation. I don't know of any human studies, but maybe we should give our patients with a rapid rise lovastatin. So at any rate, these features of osmotic demyelination usually come on about a week later: mutism, dysarthria, lethargy, obtentation, behavioral changes, movement difficulties, muscle contraction, dysphagia, all of these things, including the bulbar palsies. All of these things can happen in patients who have central demyelination. So there are a number of recommendations on the way to reduce the risk. The most important thing, I think, is to limit the rate of correction in those patients who have chronic hypernatremia. And as you can see here, 10 to 12 milliequivalents per liter, millimoles per liter, whatever units you use, in 24 hours, and then 18 in 48. Sometimes that's difficult to do. You might do an intervention and see it rise faster than that. You can always give D5W to slow that rate of correction down if you need to. You probably want to slow that down in patients who are at high risk for myelinolysis. And what we know is that women of menstrual age, those patients with hypokalemia and liver disease, poor nutritional state, seem to be at a higher risk of central demyelination than those patients who don't have those things. I think the elderly are less risk as well for some interesting reason. And those patients who have renal failure seem to never get, they have tremendous changes in serum sodium, and they seem to never get central demyelination. The ones that I have seen have demyelination have all been patients with diabetes insipidus who were treated with vasopressin normally, and for some reason became very hyponatremic. One case was chemotherapy. They got a lot of IV fluids with chemotherapy. Another case was a kid who went to a keg party at a fraternity house when he was in college. Another one was a woman who wanted to drink a lot of water to lose weight. These were all people treated with vasopressin. If a normal person does any of those things, they shut off their vasopressin and they go pee. If you take DDAVP, you retain all that water. So these people develop severe hyponatremia. Sodium's a 104, profound symptoms, acute hyponatremia. where you wouldn't think they would get demyelination, but they were hospitalized, their vasopressin is held, and they're fluid restricted. And the problem is when the vasopressin wears off in 12 to 18 hours, they start peeing, they get very dehydrated, they're still fluid restricted, they're very thirsty, they can't defend against severe hyponatremia, and their sodiums go from 104 to 165. And those are the ones that I see that get demyelination. So it's the one caution. If you have a vasopressin-treated patient, you have to be very careful. And you actually have to start giving vasopressin when they're hyponatremic, when their vasopressin wears off, so you can control the rate of rise of their sodium. Either that or start hitting them with IV fluids. But most of them you need vasopressin before they have full resolution of hyponatremia, and you lift the fluid restriction when they become thirsty. So those are the errors that I've seen. I think it's the group that's most at risk in my practice. So back to that original plan of acute versus chronic hyponatremia. If it's acute hyponatremia, you can correct rapidly, and that's acceptable, 1 to 2 milliequivalents per liter. If you have a patient who's in arrears and has coma or seizure, what have you, they need acute therapy. I look at therapy for hyponatremia as acute or subacute, or acute or chronic therapy, subacute, whatever term you want to use. But sort of like, how severe is the patient? What do I need to do? Do they need acute treatment, or can I sort of go about my business and get their sodium up slowly? So if a patient has severe neurological compromise and is in danger of dying of cerebral edema, you need to do something quickly, and you need to do acute therapy. And whatever acute therapy you choose, you want to sort of have 3 endpoints. When the patient's symptoms are abolished, so if they have a sodium of 115, they've had a seizure or they're comatose, you want to get that sodium up, and you want to stop your acute therapy when their symptoms are better. So when they come back neurologically, for example, when they have achieved a safe serum sodium, and for most people that's greater than 120. If you have a brain tumor, maybe safe is 125. You have to sort of look at your patient individually. And then if you have a total magnitude of correction of 18 milliequivalents, say they're 102 and they're up to 120, that's when your acute therapy is over. And when I say acute therapy, we're usually talking about 3% saline. And I think 3% saline is a very dangerous drug and should be used in limited circumstances. The problem at UCSF is every neurosurgery resident sees a sodium 130, they put the patient on 3% saline. And I've tried for 10 years to change that behavior, and there's just something in their textbooks they're reading, and you can't change that dangerous behavior. I think that 3% saline should be used in patients who have significant neurological symptoms such as seizures, altered mental status, or coma, when the likelihood of cerebral edema outweighs the risk of demyelination. And I use it very judiciously and very aggressively as well. So when I was in my training, for example, we were taught start at 30 milliliters per hour. If that doesn't work for 4 hours, go to 45, and then to 60, and then to 75, and then to 90. The problem is if you do that sort of approach, by the time you finally get the patient on enough 3% saline, they have chronic hyponatremia because you've taken a day or two to get it there. So I was taught to be afraid of 3% saline, but not how to use it correctly. And what I do now is I'm very aggressive with it. So I aim, if I'm going to use 3% saline in a patient, I aim to get their sodium up by 1.5 to 2 milliequivalents per hour for 3 to 4 hours or more, or till the sodium gets to 120. So I'm going to use a big dose. I'm going to get them up quickly, and then I'm going to stop it. I'm not going to mess around for a few days with it. There are lots of formulas for estimating sodium needs to determine your 3% saline infusion rate. Last I checked, there are about 6 of them published in the nephrology literature. I'm not smart enough to remember those things. And if you use that one formula I just showed you, based on this calculation of sodium and all this stuff, and how you can figure out how much a liter of 3% saline would raise the serum sodium, you can figure out the rate of serum of 3% saline you need. However, what I do is just basically the rate in milliliters per hour is the desired rate of rise in sodium and milliequivalents per liter per kilogram of body weight. So if you weigh 70 kilograms and you want to raise the sodium by 1.5 milliequivalents per liter per hour, you would multiply 70 by 1.5 and give 105 milliliters per hour, which sounds like a lot, but it works. And you use it for 3 to 4 hours and you're done. You get to your target and you're finished. So I recommend aggressive use. This is what I've been doing for about 10 years, and it works. And you have it on and you have it off, and you don't have this 2 to 3 days of using it trying to sort of get your patient better, and you treat acute hyponatremia acutely before it becomes chronic hyponatremia. So let's talk about chronic therapy or standard therapy that's not acute or emergent. And everybody talks about fluid restriction. There are formulas that you can use. I think it's the serum sodium and potassium divided by the urine sodium. If that, I think, is, I don't remember the number, 0.5 or something like that, or less or greater, fluid restriction works or it doesn't work. So there are formulas you can use. And one of the interesting things that I've seen is I go to the bedside and the neurosurgery residents have written fluid restriction of 2 liters or 1.5 liters or what have you. And that's simply not enough for some patients. The way I figure out fluid restriction is I look at the urine output over a 24-hour period, if I know that, if the patient's been in the hospital for at least a day, and then I fluid restrict to 500 milliliters less than that. Now, many people with SIDH have a urine output of 1 liter or 1.25 liters, so you're going to have to restrict to 500 or 750 milliliters, and they're not going to follow that. So fluid restriction may not work. Nephrologists would say that if you just do the calculations, you'll see it's not going to work in those patients anyway, because you have to have an obligate urine flow and water flow to be able to get rid of solute. So fluid restriction's a big question mark, because if you take a patient with SIDH and fluid restrict, it's going to take a long time to be the effective therapy. Think about SIDH, if you will, as a disorder where you have a tide of water resorption. And let's say you have ongoing SIDH. So not only has the patient become waterlogged, but they're getting progressively waterlogged every day. And we don't know what that tide is going to be, maybe 250 milliliters of fluid, maybe it's 1 liter. But whatever you accomplish by fluid restriction, you're trying to make them volume negative. And to get progress with the hyponatremia, you have to make them volume negative to account for that resorption rate that their SIDH is causing. And part of this is due to their insensible water losses, so you're kind of helped out by that. But also you have to account for that resorption rate, but make them negative enough to start getting rid of some of the water they've already held on to. And that can be very difficult. And it can take a week to 10 days to achieve successful resolution of hyponatremia in a fluid restriction state. And in my experience, sometimes it only gets better because the underlying disease process is better. The pneumonia is improved, or the meningitis is better, or what have you. And you think fluid restriction worked, but it's really the SIDH just resolved. There are lots of things that people have done. Salt tablets, saline and Lasix. I don't like the saline and Lasix thing for SIDH because you have a waterlogged patient. That's the physiology. When you give saline and Lasix, you're adding salt to the mix. So now you're volume expanding a waterlogged patient. The atria stretch, atrionatriuretic peptide is released, and you get rid of the salt. So you can actually worsen hyponatremia by using salt in an SIDH patient because of that. Urea has been used. It's unpalatable. Dimeclocycline used to be the old stand-in for those with chronic outpatient hyponatremia, but the problem is it's nephrotoxic. And I've seen 2 patients who had chronic pulmonary disease who were on dimeclocycline developed renal insufficiency on that drug. So probably about, I think it was 2005, so just about 11 years ago now, a drug called Conivaptan was approved for IV use in hyponatremia, and then probably about 2008 or so, a drug called Tolvaptan was approved for use, and it's an oral drug. And these are basically vasopressin receptor blockers that block the action of vasopressin on the level of the kidney. The Tolvaptan is an oral drug. It only binds to the V2 receptor. The Conivaptan can get the V1 and the V2 receptor. One reason you might choose one drug or the other is the Conivaptan is IV. So if you have a patient in the ICU, you could use that drug in that setting if you have IV access. If you have a patient who's on the floor and you're aiming for hospital discharge and you think they might have chronic SIDH, the oral Tolvaptan is a good choice there. The one caution about the Conivaptan is it's a V1 receptor blocker. So if you have a patient with hyponatremia in a setting of cirrhosis and give that drug, you may actually lead to more portal hypertension and a variceal bleed, or you may have some platelet problems, so they might bleed more if they have esophageal varices, for example. So you have to be careful which of the drugs you use in which patients. This is a slide showing you the comparison of placebo and fluid restriction, where sodium basically just stays low for a long time and only came up to 126 or 7 after a number of days, 4 days here, versus treatment with this particular drug at different doses, where sodium was nearly normal after the first day and then certainly came up to low normal, almost there by the end of 4 days of therapy. It's the same stuff. We've used conivaptan in neurosurgical patients and published on this at our particular center in different settings, not only after pituitary disease, but also in patients who are on neurosurgical service. And basically, in our study, looking at this drug, we had patients with a baseline sodium of about 125, and after 24 hours, the sodium was 134. 5 patients required more than 1 dose. 2 required more than 2 doses. The intake and output are 1.4 liter negative on the first day. 8 patients had pituitary lesions, 6 were post-transfemoral surgery, and you can see the sodium levels at baseline, 12 and 24 hours. 6 milliequivalent changes in 10 hours was the average with no recurrent hypernatremia. So we found this drug to be very effective in our center. The pituitary patients, for example, used to spend a week in the hospital with hypernatremia. They would go home, have hypernatremia, come back with the disorder, be admitted to the hospital, stay in a week on fluid restriction. Now we get people out of the hospital in 24 to 36 hours. So the drug can allow you to shorten the length of stay in those particular patients. And we've also seen the drug tolvaptan be used successfully in patients who had brain tumors and needed to go to surgery, but they were too hypernatremic and brain edematous, so we would correct their sodium for a few days, and then they would go to brain surgery. We've seen them have actually a shorter time to go to surgery versus those who have to sit for a while on fluid restriction, wait for the sodium to come up enough for the neurosurgeon to go in. This same sort of slide showing you tolvaptan, the oral drug, versus placebo, and here's the drug showing a normalization of the sodium in a couple different studies. So these drugs afford a good way to treat SIDH. Just due to vasopressin excess, block the vasopressin receptor. You get a little bit of a nephrogenic diabetes insipidus, and your sodium level comes up within 24 hours. So it's a good way to get your patient oriented, sometimes after just 1 dose. If their SIDH is already over and you're just dealing with a hypernatremia, it's a good way to get the sodium level up to normal so you can feel like you can safely discharge the patient. The literature shows about a rate of rise of in excess of what we want in about 10% of patients, so you have to be careful. No one in the literature that I know of with conivaptan has had central demyelination, but I think there's one case report with tolvaptan in a patient that had central demyelination with a rapid rise. And the key thing, though, is if you see that the sodium's come out quickly and it's a chronic hypernatremia, just give D5W. That's what we do at our institution. We've had to do that a couple times, and usually we start at 125 milliliters per hour. If you look at the neurosurgery residents often ask me, how do I know if this drug's working? When's it going to work? So, they have a hypernatremic patient. They give a drug PO or IV. They want to know when it's going to work. I tell them to go to the bedside because the patient's going to start peeing and the urine output's going to pick up before they even see a change in the sodium. And that's what we follow. We look at the intake and the output about every 2 hours, and the nurses record those data, and we can see when the drug's going to work. And most patients are 1 liter to 1.5 liters negative on the first day. And then you lose an additional 1 liter to 1.5 liters on the second day, even after the first dose. Interestingly, if you look at the average-sized adult who has a sodium of 125, they're anywhere from 4 to 6 liters positive water if they have SIDH and have a sodium of 125. And that's what most of the literature using these drugs bears out. You'll get about a 4-liter water clearance in a 4-day period when you use this drug in patients with SIDH, and you'll see normalization of the sodium. So it just gives you an idea of how much work you have to do when you're watching the urine output. So we also have published another paper looking at sort of the history, if you will, at UCSF of hyponatremia after pituitary surgery. And this basically shows you in the patients we studied what the mean correction rates were for the serum sodium per hour in patients who had basically no treatment, fluid restriction hardly better than that, salt tablets, 3% saline, Vaprazole, and tolvaptan. So these drugs actually are better than no treatment or fluid restriction in bringing the serum sodium level up. So we thought this was an interesting way just to see how our patients are benefiting from the different treatments and what's effective. So that's pretty much the discussion. I'd be happy to take any questions from you at this time. Thank you. Yes?
You mentioned at the start that patients with HIV are more likely to be hypernatremic. Why is that?
Two main reasons. So when you look into the literature, what you find is that a number of them, this was basically from old literature when a lot of people had pneumocystis were treated with Bactrim, and they were getting salt-losing nephritis as a result of the sulfa drug. And the other thing is that for some reason, I don't understand the physiology, a lot of patients with HIV were getting hyporeninemic hypoaldosteronism and having basically mineralocorticoid deficiency. And excuse me, I believe that data that I showed, the 30%, was from the HIV unit at Hopkins at the time. So this was before all the antiretroviral drugs were just starting to hit the scene when that was coming out. So most of those patients had true AIDS rather than just positive HIV status. So, yes.
So after brain surgery or pituitary surgery, sometimes it's very challenging to differentiate between salt wasting and SIADH.
Right.
How do you approach it?
You know, that's a very good question, and there's been a lot written in the literature about that. And a lot of people think that there may be salt wasting may be more common than we believe. And I think that when I look at our UCSF, and I haven't written a paper on this yet, but I've sort of studied it in my mind and keeping notes in the office and all of that. Of every, let's say 10 hyponatremic patients, probably 6 have pure SIDH, 1 has salt wasting, and the other 3 have sort of a mixed picture. And if you look at the neurohumoral and hormonal responses to injury, and I think of injury as a brain operation or something like that, you can have activation of the renin-angiotensin aldosterone system, cardiac output increases with stress, etc. You get renal salt losses, and patients can actually have salt wasting, brain natriuretic peptides produced. Those patients can have salt wasting as a consequence of that. So they can have what looks like cerebral salt wasting, but they can also release vasopressin and have SIDH. And it can be difficult in those patients to decide which treatment approach you take, whether you fluid restrict and give Avaptan, or you give IV salt or oral salt, for example. So in those patients, we simply go with what looks more like the cause, what looks like it's the more predominant factor. I think the cerebral salt wasting patients who have the pure disease, they're the ones with the BUNs of 20 and the creatinines of 1.5 or 1.3 or something like that. The people with SIDH usually see a BUN under 10, a creatinine of 0.5 or 0.6. The uric acid levels are very low in patients with 2, for example, in SIDH, but you might see it normal or elevated in those with cerebral salt wasting. So that's one, and people who have anemia are probably more likely to be salt wasters for some reason. Giving a transfusion can help with the salt wasting. So sort of look at it that way and just do a gestalt to figure it out. The ones who have the mixed pictures, though, will usually sort of see BUNs of maybe 15 and creatinines of 1. And their urine sodiums will be really high, 500 instead of, say, 200 where we'd like to see it with SIDH. So we tend to sort of favor giving salt to those patients. Interestingly, most of the cerebral salt wasting we see is patients with CNS lymphoma. And in a few patients who've had intraventricular hemorrhage, we've seen it as well. Almost everybody else has a mixed picture or SIDH. So those are the only states that I can remember seeing CNS lymphoma, intraventricular hemorrhage, with drains and instrumentation and things like that to get the salt wasting state. We had 2 patients last week who the residents did not consult me on. Well, I say last week, it's really 2 weeks ago. The residents did not consult me on, but they were managing based on some of the things that I had taught them. And they had patients on 3% saline who were getting worsened hyponatremia. It looked like they truly had salt wasting. A treatment with 3% saline got the sodium up to normal. And then on 50 milliliters per hour, 3% saline, because they'd backed the dose off, the sodium levels started falling. So they couldn't understand that, didn't know what to do. And to me, I thought, okay, you probably had salt wasting. Now you probably have SIDH. And what was happening is that they were giving patient 3%. Probably the atria was kicking in, making atrial natriuretic peptide. They were losing the salt, but retaining the water because they had a vasopressin excess. And when we stopped the 3% saline in both of those patients, their sodium level normalized. So it's sort of the reverse of what you expected. And I'd never seen that until 2 weeks ago. So there's always something new that challenges you to think about what's going on with the patient. So you had a question, sir?
Yeah, you mentioned antidepressants can have an effect with you. What's happening?
Yeah, if you read the literature, it's not really clear. Some people think that it leads to vasopressin secretion. Others say that it potentiates vasopressin action. And I think it's not really clear precisely what's going on. But most of them are the SSRIs, most of the guilty ones. But I think all the classes have been shown to have some hyponatremia associated with it. But, Zoloft's the number one in my practice. If I get a referral on the outpatient setting for someone who's hyponatremic, usually they're on Zoloft. If it's an antidepressant. So it seems to be the most common one that gets referred anyway. Whether it's the most common one, I don't know. It's the most common one referred to me.
What levels do you see? Like a Zoloft?
The lowest I've seen is 125. Most time you're seeing 128 to 130 or so. It seems to be 130 is a trigger that would prompt someone to make a referral anyway in my practice. But then the analeptic medications, Keppra, Tegretol, those drugs, you can see 128 to 130 with fair regularity, probably 10 to 15% of patients on those drugs. And our guy who does brain surgery for seizures, for example, sees it all the time in his patients who come in. He's always asking me questions, and we decide to fluid restrict them and watch them, or maybe try to operate to treat their epilepsy, but it's pretty common in that setting. All right, so thank you for the opportunity to be here today. Have a good day.